Good evening, everyone. Welcome to our TIF Talk Tuesday. My name is Wendy Profit. I'm with Endogastric Solutions. Along with me this evening is my co-worker, Karen Girth, and our special guest, Dr. David Forcione out of Boca Raton, Florida. Dr. Forcione is a board-certified gastroenterologist who specializes in complex endoscopic evaluation of the pancreas and bile ducts, as well as the diagnosis and treatment of Barrett's esophagus. Dr. Forcione earned his medical degree as valedictorian from Boston University School of Medicine. His postgraduate training included an internship, residency, clinical fellowship, research fellowship, and advanced endoscopy fellowship at Massachusetts General Hospital. He then served as an instructor and assistant professor of medicine at Harvard Medical School, where he also completed the Harvard Leadership course. Welcome, Dr. Forcione. Thanks for joining us this evening.
Thank you so much, Wendy and Karen, for having me. I look forward to lots of good discussion and questions from the audience.
Perfect. Well, that being said, let's go ahead and jump in. Folks, you may have noticed tonight that we had a little bit different signage rolling into the program. You see that we have the words "Fight GERD Up," and those are in recognition of Esophageal Cancer Awareness Month, which happens in April of every year. It kicked off this Friday, and we are engaging in several different activities this month to help promote awareness about esophageal cancer, its causes, its also the hope that it can be prevented. So we're going to spend a little bit of time on that this evening. First, Dr. Forcione, let's go ahead and start with what GERD is and what patients typically experience as far as symptoms go.
That's a great starting question. So GERD is extremely common. So what GERD actually represents is gastroesophageal reflux disease. And that's a complex term, but if you break it down, it basically means the abnormal exposure of your esophagus to fluids and food materials and digestive enzymes that your stomach makes that is abnormally being exposed in your esophagus. Normally, all of those components stay in your stomach as part of the digestive cycle. When people have GERD, that is the pathologic exposure. It represents a pathologic exposure or abnormal exposure of your esophagus to those injurious substances. GERD means different things to different people. It could be run-of-the-mill heartburn, acid indigestion, but it could also mean having a chronic cough that is unexplained. It could mean having a hoarse voice, a raspy voice, throat clearing. It could be having recurrent pneumonias because of acid wash up into the esophagus. So it means it has different clinical manifestations in different individuals, but at its baseline, it all comes from the same process, which is the abnormal exposure of those contents into your esophagus. It's extremely common. The body is engineered to have defense mechanisms to prevent stomach acid and stomach contents, bile from coming up into the esophagus. We're all built to prevent that, and that's through a number of mechanisms. We have a muscle, which is the valve at the bottom of the esophagus called the sphincter muscle. That is engineered to reduce the amount of reflux into the esophagus. We have a diaphragm, which is the main muscle that separates the chest cavity and the abdominal cavity. That also imparts a anti-reflux mechanism in your body. And there are other factors that can deteriorate over age. Ligamentous structures that keep the esophagus in the chest and the stomach and the abdomen also deteriorate over time. So we're built to prevent reflux. Unfortunately, like many parts of the body, things that are built to work can often decay over time and become less effective. And when that happens, you develop significant reflux or pathologic reflux. So everybody, no matter how good their anatomy is, can have reflux. If you eat a little bit too much or drink a little bit too much, you can have intermittent reflux. It really becomes a problem when it's frequent and happening on a more regular basis and affecting your quality of life. That's what we would call pathologic reflux. There are people that actually don't feel the reflux. It can be, as we said earlier, it can be more in the form of a cough or just a raspy voice or a throat clearing that actually represents reflux. But as I said, the body is engineered to defend against that, but because of age-related factors, anatomic factors, dietary factors, and the obesity epidemic, we're seeing more and more pathologic reflux, more patients who are having significant reflux, and unfortunately the complications of the reflux.
Very good, thank you. So can you talk a little bit about recommendations for managing GERD?
Yeah, so there's a spectrum of options that we discuss with patients, and like any treatment paradigm, we start with the the treatments that are least likely to give any type of harm to the patient, likely to give some relief, and then we work our way up depending upon the response. So the usual initial treatment strategy for patients is to recommend what we call an anti-reflux diet, anti-reflux lifestyle, and that can take on a lot of different meanings. There's millions of blogs on the internet that describe the perfect anti-reflux diet and the perfect anti-reflux lifestyle. The bottom line is it's not the same for every individual. What bothers one person may not bother another person, and that's important to remember, that at the end of the day, it's largely an individualized approach when it comes to diet and lifestyle. There are some definite generic or general recommendations that we have for patients, and I'll list them for you. So we know there are certain food items that clearly reproduce or cause reflux in just about everybody. And that's because we know that these things either relax the muscles of the esophagus to increase the risk of reflux, or they distend the stomach, make the stomach bigger, and that promotes reflux as well. So the most common ones I tell patients are alcohol, caffeine, and carbonated drinks. Those are the most likely to produce reflux. People also, describe spicy foods and acidic foods. That is less predictable. That is generally a more individualized thing. Some patients clearly have more reflux when they eat those foods, but the ones that I tell patients over and over again is alcohol, caffeine, and carbonated drinks. Those reproducibly will cause reflux. Probably even more important than those things are separating when you go to bed from the last meal. It takes about 3 to 4 hours for people to empty their stomachs. If you eat and go to bed immediately lying down, you're losing one of the important defense mechanisms, which is gravity, of preventing food from coming up from your stomach and your esophagus. So if you come up with a scenario where you just had a large meal at a restaurant, you go to bed within 45 minutes or an hour of that meal, it's going to come up on you overnight, no matter how good your anatomy is. You're at risk for having reflux, and that often can be a silent reflux. You may not be awoken from it, but those are the main things I tell people. Don't eat before you go to bed. At least give some time to allow your stomach to empty. Minimize caffeine, alcohol, and sodas. That's the beginner recommendations. After that, we start thinking about antacid medicines. Remember, all of the medicines that we have for reflux target acid. That is the only class of medications that we have to offer patients, both on the over-the-counter level and the prescription level, are antacids. We don't have medications that specifically target the other components like bile, which is another digestive juice that can injure the esophagus just like acid can, and also just your liquids and foods that you eat. If those come up into your esophagus, they can cause trauma to your esophagus and promote reflux symptoms. So if you think about it, the only pharmaceutical that we have is an antacid, and we start with Tums, Maalox, Gaviscon, topical antacids, and then we work our way to prescription antacids, what people would recognize as the PPI medications, Prilosec, Protonix, Nexium. And truthfully, that revolutionized the treatment of ulcer disease and reflux when they were introduced, 30, 40 years ago, and they do provide great benefit for a significant number of people. Unfortunately, there is a very large contingency of patients who continue to suffer from reflux symptoms despite taking those medications. And people come to us very frequently and say, look, I'm compliant with the medications, I'm compliant with the diet, but I still have symptoms. And the answer, is very simple. And that's not because you're not taking it properly or it's not working in you. It's an anatomic problem. It's a mechanical problem where you've lost all of the normal defense mechanisms that your body has for preventing reflux. The valve is too loose. You have a hiatal hernia, which means part of the stomach is now in the chest cavity as opposed to the abdominal cavity, and that also promotes reflux. So all of these anatomic factors will create an environment by which medications will no longer work in a significant number of patients. And that is clearly an age-related phenomenon. So it's very common to see patients respond when they're very young, and as they get older and these defense mechanisms start fading or weakening, we start seeing refractory cases of reflux. And that's where we start thinking about other options, which are procedural anti-reflux procedures. And there's both endoscopic, there's surgical, there are hybrid procedures. So we're fortunate now that the TIF procedure has become available, that we now have a less invasive option for treating reflux disease. And it's used in patients who not only have refractory symptoms or symptoms that persist despite medications, but for patients that might have side effects to the medications or who simply just do not want to take medications indefinitely. We do have other options now.
Very good. Thank you for that. We'll circle back to the TIF procedure in just a second. Before we get there, though, for those patients who have tried the treatment options that you just spoke about, and their symptoms are still continuing or they're progressing, can you talk a little bit about what happens when GERD is unmanaged? Maybe they're taking something and they feel like they just have to settle for the pain that they're going to have, or they think, no, it's just going to go away on its own because maybe there's one day a week that I don't have it. We want to make sure that we're paying proper attention to what GERD can possibly do if it's not properly treated.
Yeah, that's a great question. It's important to remember, and it's easy for all of us to forget this, that having reflux is common. So it's part of being a human being and part of eating and digestion, but it's not right to have reflux on a regular basis and requiring medications on a regular basis. That is a medical condition. That is what we would call pathologic reflux or symptomatic reflux disease. And I think one of the challenges that we all face is that because there's just a huge number of antacid medicines that are available over the counter, any pharmacy, any grocery store, any gas station, in fact, will have antacid medicine. So it's kind of made it seem like it's normal to be, taking Tums 4 times a week or, sucking down Maalox. It's not normal. And I think it's important for the audience to, hear that and make that an important part of the awareness, is that taking antacid medications is considered a pharmaceutical treatment of a disease. And if you're taking a prescription medication, but still having to take additional antacid medications over the counter, that means you're not adequately responding. And it has nothing to do with the medicine not working for you. It has everything to do with the fact that there's a mechanical problem. It's an anatomic problem that needs to be fixed. We know from years and years of data regarding untreated heartburn. So this was laid out very nicely by a large study done in Scandinavia, I want to say about 20 years ago now, where they were the first to show the link between reflux and esophageal cancer. And this sort of became popularized as, GERD can kill, because untreated GERD, unmanaged GERD, inappropriately managed GERD, undermanaged GERD can lead to changes in the lining of the esophagus. So let's kind of talk about that a little bit more. So if you have frequent episodes of reflux, and that's reflux of acid or food products or bile, your esophagus does not like that. The lining of your esophagus, which is very much like the lining of your cheek. So if you just open up your mouth and look at the inside of your cheek, that is the lining of your esophagus. That is not supposed to see a lot of acid or bile. It's not designed to see that. When it sees that, it goes through a process of injury, inflammation. And if it happens over and over again, people can develop complications because the esophagus does not want to see that inflammation happen. The first thing that happens is you develop ulcers in your esophagus. That can lead to scarring in the esophagus, can lead to narrowing in the esophagus. In a subset of patients with reflux, and we usually consider the number to be about 15 to 20%. So 1 in 5, 1 in 6 patients with heartburn will develop something called Barrett's esophagus, which is a condition where the lining of your esophagus becomes a precancerous lining. That lining, in fact, is your body's response to too much acid or bile. So whenever we see it, we know that those patients have had chronic reflux. So it's something we diagnose with endoscopy. It is a defense mechanism by your esophagus because the Barrett's tissue is stronger. It's more resilient against acid. Unfortunately, it comes at the cost of that lining being more sensitive to mutations and carcinogens. So over time, that Barrett's tissue that your body lays down in response to acid can transform into a cancerous lining. So it's the paradigm is you start off with reflux. A subset of patients with reflux will develop ulcers. A subset of those patients will get Barrett's, and a subset of those patients will get esophageal cancer. So we talk about esophageal cancer, it all leads back to reflux typically being the underlying pathway. So basically to the point where it's very, very unlikely for an individual to get esophageal cancer if they don't have reflux disease. So controlling reflux, we know, will lead to less frequency of esophageal cancer.
Good, thank you. Okay, well, let's circle back to treating GERD beyond the medications. Can you talk a little bit about what the options are as far as being able to treat GERD?
So, as we talked about earlier, just about every patient will start off with a medical regimen, a medication regimen, and a diet and lifestyle regimen. I think that is still, ubiquitously considered the standard initial treatment. And many patients have a good response, but we now recognize that many patients don't have a complete response. Furthermore, may have side effects from the medications. We know that chronic use of PPI medications, which are like Prilosec and Nexium and pantoprazole, can lead to some significant conditions. So we know for sure that Bone density will go down reliably in patients on those medications chronically. So osteoporosis, which can lead to fractures, hips and spine. There's good evidence that kidney disease can accelerate on chronic PPI therapy. There are some mineral deficiencies. I recently had a patient who had severe magnesium deficiency on chronic PPI therapy, to the point where she was requiring intravenous magnesium therapy on a weekly basis. We ended up stopping her PPIs, did a TIF procedure, and she's now off, all PPIs, and her magnesium has been able to be controlled just with oral medication. So that's an uncommon, extreme version of mineral deficiencies, but iron deficiency, vitamin B12 deficiency, electrolyte deficiencies are all known to happen from chronic PPI therapy. So, now that we know that there are a lot more of those patients than we ever thought, people that are still symptomatic, because remember, the medicines only treat the acid component. They do nothing for bile. They do nothing for regurgitation. So if you have a hernia and a loose valve, no matter how much antacids you take, you're still going to have regurgitation and reflux. So fortunately, we now have a number of options. Traditionally, the go-to treatment, procedural treatment for unmanaged or refractory reflux is surgical. And typically that is what we call the Nissen surgery, or the Nissen fundoplication, where a surgeon will do a tightening of the valve between the stomach and the esophagus, will correct a hernia, and tighten the valve between the stomach and the esophagus. Typically done either as an open surgery or a laparoscopic surgery in most scenarios. And it's a tried and true surgical technique. It's very, very effective as an anti-reflux procedure. The problem with that approach is that a significant number of patients, although their reflux is controlled, they will have the potential of developing side effects or complications from the procedure. And as gastroenterologists, we see these all the time. Patients who have had surgical anti-reflux procedures can develop significant side effects. Gastroparesis, which means your stomach empties slower, and that can cause nausea and vomiting. After a Nissen surgery, you can no longer belch because of the anti-reflux procedure. Patients may have diarrhea. There's a condition called gas bloat syndrome, which is sort of a sensation of trapped gas in the upper abdomen that can be very uncomfortable. And it's certainly not all patients, but the frequency is such, around 15 to 20% of patients getting these side effects, that it can be very debilitating for patients. So in light of that, fortunately, there's been innovation in our approach to this condition, and we now have a minimally invasive approach using the TIF procedure, which is the endogastric solutions device, to basically replicate the good parts of the Nissen surgery, the anti-reflux components, the tightening of the valve, but without the same side effects. So that is the major benefit of the TIF procedure, is you have the anti-reflux benefits of the Nissen surgery without the side effects. If you look at the TIF data, which is now out, I want to say 11 or 12 years of patient follow-up, you have a much lower side effect profile compared to the Nissen surgery. We're talking less than 2% of patients will have any significant adverse events. We don't see the swallowing problems that Nissen patients have. We don't see the gas bloat. We don't see the gastroparesis. We don't see any of that. In fact, what we do see, though, is the same anti-reflux benefits. So patients who've had Nissen surgery and who've had TIF surgery, there's comparable benefit. So the effectiveness of the TIF procedure is comparable to a surgical treatment, but without the side effect profile. And that's what has been really the the main draw for this procedure for patients is the ability to control symptoms more reliably, come off medications, but not have the invasiveness of the Nissen procedure and not have the side effects.
Excellent. Thank you. Well, I see we've had some questions coming in. I'm going to go ahead, turn it over to Karen, and fire away.
Right. Thank you, Wendy. Dr. Forcione, we have a few questions around Barrett's esophagus. One being from Lynn, can Barrett's esophagus be reversed? And then Tyler would like to know, I have Barrett's, and can I get a TIF procedure?
Great question. So Barrett's can be reversed. We use our treatments to primarily prevent the progression of Barrett's esophagus, meaning most of our treatments, whether it's antacid treatments or anti-reflux surgical treatments, are geared towards retarding or limiting the progression of Barrett's. There's actually good data both from PPI therapy, medication therapy, and from surgical therapy, meaning patients who have had Barrett's who undergo a Nissen surgery, or Barrett's who have been on chronic PPI therapy, that has shown that you can retard the progression of disease from Barrett's to cancer. That's not questioned. What remains somewhat debatable and controversial, and what has not been really borne out, is can we reverse Barrett's just with a procedure? The answer is we don't know, but the likely answer is probably not. So Barrett's, once you have Barrett's, we have mechanisms of getting rid of it. We have what we call ablation procedures that we can use to get rid of Barrett's, and that's very commonly employed by gastroenterologists. It's a technology that's been out for almost 20 years now, this what we call radiofrequency ablation. So there are options, but I wouldn't look at any of these procedures, whether it's a Nissen surgery or a TIF surgery or even PPI therapy, as ways of getting rid of Barrett's. There's really no substantial data to support that. What we do have data for is that it does retard the progression. So all of these therapies reduce reflux, and therefore, since we know reflux is the promoter of Barrett's esophagus to cancer, controlling the reflux is an important part of that treatment regimen. I think the other question that was asked was, can you have a TIF procedure if you have Barrett's esophagus? So the answer is definitely yes, and I have had many patients with Barrett's undergo the procedure. My own protocol, and it varies across the country, across providers, is at what point do you employ a anti-reflux procedure in somebody with Barrett's? So in my own practice, I would do the procedure if we've confirmed that the patient does not have what we call dysplasia. So dysplasia is the step sort of in between Barrett's esophagus and cancer. So it's a finding on our biopsies that we take of the esophagus that the pathologist will say Barrett's with dysplasia or Barrett's without dysplasia. If a patient has dysplasia, to me, the most important thing to do up front is to get rid of the dysplasia, and we do that with an ablation procedure. Once we've gotten rid of the dysplasia, then it's a great window to do an anti-reflux maneuver, and that's when I employ it. So once I've gotten rid of all of the dysplasia, then we'll do the anti-reflux procedure. If you just have Barrett's and no dysplasia, then certainly you are a candidate for a TIF procedure. The TIF procedure itself does not change our ability to monitor your Barrett's or follow your Barrett's, but I do think it's important to get rid of the dysplasia first before embarking on the anti-reflux procedure. I've had a number of patients now that we've been doing ablation on for their Barrett's with dysplasia, and the one caveat to what I just said to you about the dysplasia is I've had some patients who have refractory Barrett's tissue, meaning no matter how many times we ablate them, we cannot get rid of their Barrett's. And in those cases, it's very clear. It's because when you ablate the Barrett's tissue, get rid of it, the body has to fill it in with normal tissue. It's not going to fill it in with normal tissue if you have ongoing bad, uncontrolled reflux. So I've had several patients now who have undergone the procedure simply because we cannot stop doing the ablation, and it does help us stop the ablation process.
Well, we have a couple more questions, but I did want to just make a quick comment from Sandra. She said, you did my TIF surgery and it was 100% success, so thank you. So
Hi, Sandra. Thank you. Sandra's our favorite.
And Lori has a question. Can TIF cause vagus nerve damage?
That's a phenomenal question. I'm sorry, who asked that question?
Her name is Lori.
Lori, very, very good question. You obviously have read a lot about this condition and know a lot about it. So the vagus nerve is a very important nerve for the digestive system. It travels alongside the esophagus anatomically, and once it passes beyond the esophagus, it branches into many little branches around the stomach. The vagus nerve is responsible for motility or movement in the GI tract. So it's responsible for normal motility in the stomach, what we call peristalsis. So if you don't have a vagus nerve, two things happen. Your stomach doesn't empty normally, you don't have normal muscle movement in the stomach, and your stomach doesn't make acid. Many, many years ago, that was a surgical treatment for ulcers of the stomach, was doing what's called a vagotomy, just cutting the vagus nerve. It gets rid of the acid production, but at the cost of limiting your stomach movement, normal motility. So if you cut the vagus nerve or damage the vagus nerve, you can develop gastroparesis or slow stomach emptying, and that can cause nausea, vomiting, feeling full all the time. It can be a very difficult symptom to manage. The TIF procedure does not affect the vagus nerve at all. So because the TIF procedure is done what we call endoluminally, meaning the scope, the device is within the esophagus, done by an endoscopy rather than from the outside, there's no injury, no potential for injury to the vagus nerve. So there have been no reports, certainly to my knowledge, certainly none that I've seen, where the vagus nerve is injured during that procedure. On the other hand, the vagus nerve is commonly injured in patients who undergo a surgical anti-reflux procedure because in the process of doing the surgery, and this is at no fault of the surgeon, there's traction or movement of the vagus nerve as the stomach is pulled back into normal position, as the stomach is wrapped, or what we call the fundoplication, around the esophagus. That can put compression or torsion on the vagus nerve, and that's what can lead to this gas bloat syndrome, this gastroparesis that can happen after a Nissen surgery. We just don't see that at all with the TIF procedure.
Thank you for that. And then I have one last question, and I'll hand it back to Wendy. But Tina is telling us that she was diagnosed with gastritis 3 years ago. She's been on medications and has severe nausea and vomiting, and her stomach doesn't empty out properly and in pain. I guess she's asking, what can be done to help her? Should she, start doing any diagnostic testing or workup, for GERD, or is it something completely different?
So that's a great question, Tina. It sounds to me like the predominance of your symptoms are related to your stomach rather than your esophagus. Now, of course, the stomach is connected to the esophagus, and we see a lot of conditions where there's sort of a mix of symptoms between reflux, gastritis, even sometimes gallbladder symptoms can be confused with esophageal symptoms or stomach symptoms. Your symptoms, to me, at least the constellation of nausea, pain, feeling full all the time, that to me is very typical of gastroparesis or slow emptying of the stomach. And that's also a very, very common condition. It's not as common as reflux disease, but in reality, if your stomach empties slowly, if you think about it, you're going to have more reflux. So when your stomach does not empty stomach contents, whether it's food, liquid, acid, that has another pathway to go, and that's up in your esophagus. So we know, from a lot of data and a lot of patient experience that individuals with gastroparesis often have very significant reflux. And so what it sounds like to me is you have gastroparesis, you should have a gastric emptying scan, which is a specific radiology study that is done to measure how fast your stomach empties. It's a very simple outpatient test. You're given a prepared meal. They sprinkle some radioactive material on it. You eat it. They take pictures of your stomach at varying time intervals. And it really just measures how fast that prepared meal empties your stomach. And we know from normal individuals, people that do not have symptoms, that there are certain parameters of emptying. So typically, by 4 hours, you should at least have 90% or more of what you ingested gone out of your stomach. And there are similar parameters at 3 hours, 2 hours, 1 hour. So that's a very good test for determining whether your stomach empties slowly. If that is confirmed, then we'd have to explore, why does your stomach empty slowly? Most common is diabetes as the factor. Some patients who have had hernia surgery or even Nissen surgery can have gastroparesis. Sometimes it's idiopathic. We have no idea why it happens. But if gastroparesis is what is the cause of your symptoms, then there are targeted treatments for gastroparesis that can often help. A TIF procedure is not going to be a fix for gastroparesis. It's not contraindicated to be done if you have gastroparesis, but typically in patients that I've had who have both reflux and gastroparesis, I try to really target the gastroparesis part first, get that under control, and then I'll do an anti-reflux procedure afterwards to kind of get the best of both worlds, the stomach emptying better and the valve working better.
Thank you. And we did have one more question come in before I bring it back to Wendy. But Elizabeth is wondering, are there any major physical limitations after TIF? Thinking exercise, is there anything that she should be concerned with?
I'm sorry, who asked that question?
Elizabeth.
Elizabeth, great question, Elizabeth. So in general, there are some physical activity limitations after the procedure. Maybe I can expound on that and talk a little bit about what is it like after the procedure and a little bit more about the procedure. So the procedure is done almost always as an outpatient procedure. So patients will come in from home, we'll have the procedure. Some patients, depending upon whether they have a hiatal hernia or not, and the amount of the hiatal hernia or the extent of the hiatal hernia, may need to have the hernia fixed at the same time. I would say it's maybe 60 to 70% of patients who we do this procedure on have a same-day hernia repair. So I work with a surgeon. The surgeon fixes the hernia, and then I do the TIF procedure while the patient is still asleep. That takes about an hour and a half, 2 hours to do both procedures. Still with that, most patients go home after the procedure, maybe an hour or so in recovery room, go home. There is a specific program, dietary program that we employ after the procedure, and that's very, very important to follow. The goal of that dietary program, and it lasts about 7 weeks, is to allow the procedure to do its magic, which is basically creating the barrier between the stomach and the esophagus. In order for that to happen, you have to limit the stretching of the stomach, stretching of the esophagus, to allow those sutures that we place in there at the time of the procedure to create the barrier, and that takes 6 to 7 weeks to do. So the diet program after the procedure, which is extremely important, we spend a lot of time with patients explaining that, is basically an escalating diet week to week. So week 1, you're eating basically baby food consistency, liquids. Week 2, you're going up from there. Week 3, you're going up from there. And the idea is you don't want to overeat, over distend. You don't want to put too many complex textures in your stomach at the beginning because you need the stomach to heal. And this is true for whether it's done surgically or as a TIF procedure. These are all general recommendations for people undergoing anti-reflux surgeries. You need some time for the stomach to heal. Alongside that, and just to expound on that further, so we give patients a very detailed dietary program to follow for those 7 weeks. And it can be difficult for some patients. We do, review exactly what we would recommend as far as the amount, the types of foods. It's certainly doable. The other good thing about the regimen is that just about everybody will lose some weight after the procedure, 15 to 20 pounds. And that's a combination of the diet change, but also because we're doing a wrapping in the stomach, what we call a fundoplication, we are constricting the stomach a little bit. So it does create a little bit of, I don't need to eat as much as I used to anymore type of sensation. That's not a forever feeling, but for a number of patients, that 10 to 15 pounds of weight loss is a jump start for them to say, hey, this feels really good. I like the way I feel. I'm going to change my diet, my lifestyle. And we certainly recommend weight loss for many patients who are overweight or obese as part of this program, because that we know for sure will help with control of reflux long term. So alongside the diet, which is critical, there's also a restriction on weightlifting and very arduous exercises. So I can't remember exactly the amount, but I want to say it's 5 pounds the first week, 10 pounds, week 2, week 3. After 7 weeks, you can go back to your usual regimen, but we don't want to do any heavy lifting, certainly immediately post-op. We want to limit any heavy lifting, any arduous exercises, because we don't want you to put a lot of stress on your abdominal muscles that might weaken the surgery that we just did. Of course, after the 7 weeks, you can go back to your usual regimen. Now, this does not include walking, swimming, biking, jogging. Those are all, fair game to start off with. It's just we don't want people to start doing a heavy weightlifting program or even lifting things at work that exceed the recommended amount. And again, all of these are not meant to be, punitive in any way. It's meant to allow the healing to happen and to give you the best outcome. And some patients say, well, why can't I cheat on this? And I said, you can do that, but we don't recommend it because you won't have the best outcome. And I think people understand if you're going to go through the procedure, go through the program, you want the best outcome. It's really important to adhere to the diet that follows.
Wonderful. Thank you. Well, we've come to almost the top of the hour, so we'll go ahead and close in just a second. What we always like to do is give our guests a last opportunity to share their parting thoughts to anybody out there who's maybe on the fence about coming in, who is having those concerns about the unknown. What some of the things that are maybe holding them back. What would you say to them? And we'll close from there.
Sure. Thank you. So, of course, any type of procedure, surgery will impart some concern in any patient, and that's to be expected. I think what I want to impart on the audience is that this is really a extremely safe procedure, minimally invasive, and I would strongly recommend to anybody out there who is struggling with GERD symptoms, and that again can be heartburn, indigestion, and we're seeing a lot more of the airway type symptoms, cough, raspy voice, recurrent pneumonias, throat clearing. All of those are difficult to manage with medications and diet and lifestyle alone, and it's usually because there's a mechanical anatomic problem that can only be dealt with a procedure. The procedure is extremely safe. It works extremely well. Patients can come off medications. Patients can have a better quality of life. And, I would strongly recommend at least talking to your gastroenterologist about this. They're, certainly aware of the procedure. Not all gastroenterologists do the procedure, of course, and, hopefully you're in an area where there is an expert that does the procedure. I believe the website GERD RX, GERDhelp.com. We'll give you a listing by zip code of providers in your area, and look, just go talk with them, have a discussion. I do this, every day, have discussions with patients, and just ask all the questions you want about the nature of the procedure, what it means afterwards, what you're going to feel like afterwards. I think the biggest fear is that there'll be pain, that there'll be side effects, that there'll be complications. And, the data is just very, very solid as far as low adverse events, low complications. I don't send any patients home with any pain medications other than extra strength Tylenol. That's really all they'll need. They might need a throat lozenger for a sore throat. But pain is not an issue after this procedure. It's extremely, well tolerated. And the outcomes have been very, very good, and the durability is very good. The other thing I want to mention is that because it's a minimally invasive procedure, that although it's uncommonly needed, unlike a surgical procedure like the Nissen surgery, a TIF procedure can actually be done again over time. So there are patients whose anatomies change over time, may gain weight for whatever reason, and need tightening of the valve. It can be done very simply endoscopically, to add more tightening over time. That's pretty much impossible to do surgically. So there's that, additional benefit. I personally haven't had to do that on patients as of yet, but it's been described as certainly an option for patients that have recurrent symptoms over time.
Excellent, thank you. Well, I can't tell you how much we appreciate you sharing your expertise and your time with us this evening. The viewers, I know, have gotten a lot out of this, so thank you again. As Dr. Forcione mentioned, if you are looking for a TIF expert in your area, you can visit GERDhelp.com and type in your zip code in the top right corner, and our physician locator will show you who is in your area. Also, to help your doctor when you go in for a consultation, we have the first of its kind, a GERD Help mobile app that patients can use for education and also recording their symptoms, keeping track of their vitals, etc., so that they can have a nice little summary available for their doctor when they go see them. You can download that on your iOS store or your Android store, or you can go to GERDhelp.com and select Get the App. There are QR codes there that you can take a quick picture of, and it will do the download for you. So we appreciate everybody joining us this evening, and also joining us in the fight against GERD. As we've learned this evening, it can lead to things that some may not have considered, like esophageal cancer. So we appreciate your expertise again this evening, Dr. Forcione, and we'll see everybody next week. Take care and good night.
Great. Thank you. Good night, everybody.